Hi, everybody.
Dr. Ryan.
Hello, Rita.
Glad you could join us.
I managed. I'm on service, and I was still able to get on. So
Yeah, I'm on service too. That's
Thank you so much for taking time out of your busy schedule.
Thank you, everyone. Yeah. I will go ahead and get started as we have a lot to cover today. Good afternoon, everyone. I am Sai Muktapuram. I'm a neonatologist from Cincinnati Children's Hospital. On behalf of AAP Section on Neonatal Perinatal Medicine, TCAN, welcome everyone to this 52 and 52 RCT Challenge Virtual Journal Club session. Thank you for joining us. Just housekeeping announcements. Please mute yourselves if you're not speaking. Please send your questions to myself or my co-host, Dr. Viral Jain, who's from UAB. Please fill out the feedback survey at the end of this session. And it's been more than a year since the 52 and 52 RCT challenge has started. Dr. John Zupancic has challenged the fellows across the country and learners to read 52 landmark neonatal trials, one each week for an entire year. What TCAN has done is we've polled our Twitter audience and selected one article each month to discuss on this virtual platform with leaders in the field and great faculty mentors like the ones we have today. The trial that we'll be discussing this afternoon is pressure regulated volume control ventilation versus synchronized intermittent mandatory ventilation for very low birth weight infants, a randomized control trial authored by Dr. DeAngio, who's here with us today, and also Dr. Ryan, who's also here with us today and help us learn some of the pearls from the study. This paper today will be presented by Dr. Ahmad Al-Mazmi, a neonatal fellow from Baylor College of Medicine. We are now excited and honored to introduce our faculty mentors for our discussion, and we thank all of you on behalf of TCAN for taking time out of your busy schedules to do this and teach our audience who've attended today. At this time, I request my co-host Viral Jain to introduce Dr. Rita Ryan.
It's my pleasure to introduce Dr. Rita Ryan, who's a professor of pediatrics and a neonatologist at Rainbow Babies and Children's, and also at Case Western. As we all know, Dr. Ryan is an inspiring leader and has several leadership roles during her distinguished career with several contributions to the field of neonatology, and has authored many publications and has served as an amazing teacher and mentor to many trainees who came along. We thank Dr. Ryan for agreeing to mentor this session.
And next is Dr. Martin Kessler, who needs no introduction. Dr. Kessler is a professor of pediatrics and a neonatologist at Brown University Women and Infant Children's Hospital. Dr. Kessler is the Associate Director of NICU and Respiratory Care Services. Dr. Kessler is also considered to be the guru in neonatal ventilation field and has authored several publications and pioneered several trials and taught audience like us at various conferences. Thank you, Dr. Kessler, for joining us today. And last but not least is Dr. Carl DeAngio, who is a professor of pediatrics and the chief of Division of Neonatology at Rochester General Hospital. Dr. DeAngio has authored several publications, including this one, and has mentored several neonatologists in the field in current generation and multiple in the future. And Dr. DeAngio has graciously also agreed to join us this afternoon to provide his insights from designing this trial, as well as some of the challenges they've encountered and some of the important teaching points for us today. It is an honor to have you all as our faculty mentors. As we all know, PPD is an important neonatal outcome of interest, and it is multifactorial in etiology. Ventilator management is a key factor that affects this outcome and is a topic of interest for many today. Let us start with just a quick poll to get a sense of what current practice variation is in regards to ventilator management in our audience today. I will launch the poll and I'll give you around 20 seconds to respond to the poll. The poll question is, if clinically indicated soon after birth, what is your preferred mode of mechanical ventilation in your NICU for infants born less than 28 weeks gestation initially?
Okay, closing the poll now.
Great. Looks like we have a widely varied group, still 24% around pressure control, and the other 60% is around volume control, but whether it's assist control or SIMVs out there, and a few here and there for oscillator ventilation and high frequency jet ventilation. So with that, I will stop sharing my screen, and I'll let Dr. Al-Mazmi to go ahead and teach us about this article. So.
Thank you, Dr. Mukhtaparam. Let me pull up my presentation. See if you can see it. Can you see
You
it?
can see it.
Perfect. Is it the regular view or the presenter view?
You're in the presenter view.
Great. All right. So thank you, everybody, for joining us today. We'll be talking about an interesting paper. My name is Ahmed Al-Mazmi. I'm one of the second-year neonatal fellows at
Ahmed,
Baylor
you're
College.
still in presenter view. Yep.
Swap that. There we go. There we go. Actually, let me do.
Perfect.
Yeah, perfect.
A second.
No, not so perfect.
Go back to presenter mode.
Yep.
And if you do this, text.
Still in presenter view. If you
No.
go to, yeah, if you go to advanced sharing under the Zoom options, you can even select which portion of the screen you want to share. So, yep.
That's good.
Now.
All right. So thank you, everybody, for joining us today. My name is Ahmed Al-Mazmi. I'm one of the second-year neonatal fellows here at Baylor College of Medicine. We'll be talking about an interesting paper that I thought had a significant effect on subsequent studies, especially with our vent management for our VLBWs. So it's going to be this paper that's by Dr. D'Angio et al., where we're looking at the pressure-regulated volume control ventilation versus synchronized intermittent mandatory ventilation for very low birth weight infants, a randomized control trial that was published in 2005 in JAMA Pediatrics. So just a brief intro. So we spoke about the modern modes of ventilation, and that term really came in the 1960s, where previous to that, you had your time cycle, the pressure limited intermittent mandatory ventilation, which was not synchronized. And that led to you having your breath stacking. With that, your tidal volume is not consistent because of your variations in your lung mechanics, because of compliance, and the infant's spontaneous breaths. Now, with that, you end up having your ventilation-induced lung injury. That could be an outcome from your barotrauma, volutrauma, ectotrauma, and as well some biotrauma as well. So when we talk about synchronization, how is it done? There are many modes to how it's done in terms of using different receptors via whether it's in the actual tube or actually on the baby. The two common modes that we talk about are your assist control mode, where every spontaneous breath is assisted with a mechanical breath, and your synchronized intermittent mandatory ventilation, where you have a preset backup rate if the baby is not breathing, with a variable interval between your breaths. So to look at our study, we'll build up our PICO question first. And the design of the study was based off a randomized, controlled, non-blinded trial, with the population being infants with birth weight between 500 and 1249 grams, with a gestational age more than 24 weeks at birth, requiring mechanical ventilation. The intervention here is your pressure-regulated volume control mode, with the comparison being the synchronized intermittent mandatory ventilation. The outcome for the study was being alive and extubated, and the time interval was 14 days of life. So we'll be using our consort checklist, that's from 2010. It's a very extensive checklist. This is just to show you the different steps that's involved in it, if this is the first time you're joining us today. So starting with the title and abstract of the study. So the title is a very, it's an inclusive title that also has the randomized control trial as part of the title, which was something that they required in that consort checklist, which I thought was useful. In terms of the abstract of the study, I thought it was a very nicely well put study. I know that usually you do have your word limitations with your abstracts. So in terms of the trial design, it does check that box for the checklist that they asked for. It does, however, it does not include the time window of including such infants. But we'll talk about that later, where there are enrolled patients between February 1998 and October 2002. But despite that, despite the methods section being not included in that abstract, they did hit all the keys in terms of pointing to defining your participants, your interventions, your objectives of the study, and your primary outcome, which we spoke about being alive and extubated at 14 days of life. And then perhaps here, in terms of the differences they talk about, maybe adding a p-value might be nice, but I think the abstract all in all was a great abstract that met the criteria for the consort checklist. So moving on to the introduction part of the manuscript. These are the 2 points that they ask for, looking for a background explanation of the rationale, and then the objectives of the study and the hypotheses. So the way the paper was structured, the background part was very narrow, very small. It did talk about lung injury being occurs secondary to mechanical ventilation in preemie infants. They introduced the concept of the SIMV and the ACV modes. They did cite articles about improving physiological parameters and speed of ventilator weaning in AC mode compared to SIMV. And they also highlighted that there's a deficit in comparing the two long-term effects of those two modes.
So since we have the pleasure of having both the authors of the study, can you give us some more insight about how you ended up designing this study? What was the scenario in the literature at that time leading you to come up with this question?
So at the time that we planned this study, there was a significant amount of controversy, not only between what the studies thought about mostly as now is between volume and pressure ventilation. And there's also some controversy between synchronized and intermittent mandatory ventilation and assist control, as we mentioned in the background. And this was an attempt to go beyond the comparison of short-term physiologic parameters and to look at both intermediate and longer-term outcomes in these children. We designed, quite frankly, we designed the trial around the ventilators that we used, so that the modes that were available to us, which you'll get to in the methods, really reflected what was available on that ventilator at that time. But it did allow us to ask the question about the difference between SIMV and assist control modes. Does that answer the questions that you'd like to hear about?
You know, you guys, you call it volume guarantee now. This was probably one of the earliest volume guarantee modes, still with a pressure waveform, but this was like a brand new concept in neonatology. And there weren't very many randomized controlled trials. And I'll just give a little bit more color to the background. So at Rochester at that time, you may notice the first and second authors were Carl and Patricia Chess or Patty Chess, and I was the senior author. And believe it or not, we were kind of like the young Turks back in those days. And we had lost a big grant that Rochester had to do clinical research. And so everyone was a little, you know, what are we going to do now? We used to do a lot of surfactant trials, and we had lost our SCORE grant. And Carl and Patty and I met every week for probably about 2 months, maybe, Carl, I might be getting the timer. And we said, we are going to do a study. We didn't have clinical research nurses as much to help us anymore, but we were determined, we were all lung researchers. We are going to study something of importance in the lung. And we worked and worked on this until we came up with something interesting. And, so I guess my advice to people is don't give up. And you never know when something's going to, it's hard to judge in the future whether something's going to be deemed important or not all the time. And so perseverance paid off. And number 3, the title, I believe, was Carl's title. Number 2, I don't think we had consort information then, so don't hold us to that. And number 3, Carl wrote almost every word of this paper. So anything good or bad you find in there, he is a beautiful writer. And I've been very blessed to have him write most of my papers. So I'm just going to give him all the credit, but then if you find something bad, you can blame him.
Thank you so much for the insight and the
Inside scoop, yeah.
And just to add along and to get a better perspective of practices across the country around the same time or right before the study was designed, Dr. Kessler, would you like to comment on how hesitant were neonatologists to adopt some new practices versus not? Yeah.
You're muted, Marty.
Thank you. The computer told me that too. Zoom's very good. Apologies. So great question. So, neonatologists, of course, are always a little bit reluctant to adopt, like many others. Let me see if I can show you this button that I wear. I don't know if you can read it. It says, because we've always done it that way, cross out. And I do that because inertia is the most powerful force in the universe. If the young ones didn't learn that in school, they will learn it in life. So change is hard. I was working with volume guarantee since the mid-1990s. So the concept wasn't new even in 2005, much less now, but it's been a long journey. And to be honest, Carl and Rita, I always looked at your paper as a pressure versus volume paper rather than an SIMV versus assist control paper. And I only reread it in preparation for this journal club and realized, wait, that wasn't the primary goal.
Well, remember the volume guarantee modes really are a sort of a form of a pressure mode. So this wasn't, for those of you who didn't read it as carefully, really a volume ventilation paper. Would you agree with that now, Marty?
No, I mean, absolutely. So I was going to remark when the little poll went up that herein is the beginning of our struggles, which is nomenclature and understanding what is what. And you're absolutely right, Rita. There is an important distinction between volume controlled and what I refer to generically as volume targeted ventilation, which includes volume guarantee, but also PRVC and other related modes. And as you pointed out, it's a pressure controlled modality with volume targeting. In other words, the waveform is one of pressure controlled ventilation, but automatic adjustment of inflation pressure to try to target its tidal volume. And so PRVC does that. The only trouble with PRVC, of course, as implemented on the servo eye, is that the tidal volume is set and measured back at the machine, which explains, and I'm sure somebody was going to comment on that at some point, that the babies were being ventilated with tidal volumes that if you took that at face value, would be ridiculously large, but that's not what the baby actually gets. But the challenge, as we will, I'm sure at some point discuss, is that you have more than one difference between the two arms. You have the mode of synchronization, SIMV versus assist control, but you also have a difference in how you target. One is a pressure controlled mode, the other is a volume targeted mode. And,
I think as Carl pointed out, you sort of do the study based on what you're using clinically. And
right.
At that time, everybody was using pressure SIMV and this new PRVC mode, which actually can be an SIMV mode too. But in our unit, we pretty much used it all as assist control. And the nomenclature was a killer. And when I left Rochester to go to different places, you know, everyone uses a different ventilator. Why can't they just all call it the same thing? But they can't. And so you have to really, like all of you guys, when you go to a new unit, you've got to figure out what really is that mode. You know, sometimes they'll even give you the little booklet that the RTs get. Take a look at it, because I mean, what do? We ventilate babies, right? So let's try to understand what the different modes are. But I really felt like the discipline of whoever makes all these ventilators could have done a better job of putting the nomenclature so that we could understand it from hospital to hospital.
And
They
I,
don't want you to understand it. They all want to be distinctive. They all
Right,
want
I
to have a
know.
mode that's different.
and I'll just comment that it's been interesting over the years since this was published to watch this move in people's thinking from an SIMV versus assist control study to a volume targeted versus pressure limited study. And both of those are true. It's just that as the field has evolved, the question has really been the volume targeting versus pressure versus assist control versus SIMV.
So
We
one
didn't know
thing,
what we were studying at the time.
and Marty, this was published in 2005. We didn't start it in 2005, so it was still kind of new material. And Ahmed, you mentioned something about the study not being blinded. And we are hardcore, Carl and I and Marty, hardcore clinical researchers. So I can't let that pass without a comment to the rest of the folks on the call here. I really feel that you should try to blind every study that you do. It is much more convincing to the person at the end if it's a blinded study. We blinded a in and out surfactant trial, so people said it couldn't be done. We spent a lot of time, Carl and I, making that happen. You know, any number of things. So it's important to blind your studies, but we couldn't figure out a way to blind this study. So we didn't not blind it because we don't think it's important. I just want you guys to know that we do think it's important. We just couldn't think of a really easy way of doing it in this case.
These are all great insights and a good build up for the rest of the talk. So Dr. Osmond.
So exciting now. Everybody wants to hear about this, right?
Great, thank you for that input. I was gonna just move on and actually talk about the background part. I think the manuscript itself was nicely written. However, like Dr. Ryan said, the order of the parts wasn't really in a usual order. So really, to check off that box from the consort checklist, more of that background was mentioned in the discussion section. So I'll talk about them really briefly just before we get to the actual discussion points where I think most of the meat is. So in terms of the background part, they spoke about how they cited studies where they compared the SIMV to the IMV, where they said that the SIMV has a better short-term parameters without increasing risk of hypocarbia. They compared the AC mode to IMV, where they saw less variation in cerebral blood flow and arterial blood pressure. And then they saw some studies cited whether SIMV or AC compared to IMV had shorter duration of mechanical ventilation, but no overall change in BPD or mortality. The reason why I have a star there next to the BPD was because there was a Cochrane review that looked at synchronized modes did shorten duration of mechanical ventilation. They didn't alter the incidence of chronic lung disease. So more on the specific objectives and hypotheses of the actual paper, they did write that nicely. The objective was to compare pulmonary outcomes in very low birth weight infants receiving AC ventilation with those infants receiving SIMV. And the hypothesis was among infants who weighed 500 to 1249 grams at birth, PRVC would increase the proportion of infants who were alive and extubated at 14 days of life of age compared to SIMV. So moving on to our method section. Again, I'm trying to cite in the lines from the consort to make sure we're not missing any of those points. The study trial did involve two parallel groups, the SIMV and the PRVC, and there's no change to the eligibility criteria following initiation of the trial. The participants, like we suggested, were the babies between 500 and 1249 grams with a gestational age of more than 24 weeks, requiring mechanical ventilation. Their enrollment period was before 6 hours of age. And thankfully, I should mention earlier on, Dr. D'Angio did send me the protocol, which had additional information, which I thought was very useful to understand the manuscript better. And to answer the question 4B that they had there, the study data, both electronic and paper, were stored at the Vassar Brothers Medical Center for the study period.
Dr. Ryan and Dr. D'Angio, were the families consented after birth, but before 6 hours, or even consented and enrolled before birth of the infant?
I think almost all of them were consented after birth and before 6 hours.
Wow, that's like a significantly high enrollment rate within like that short time span, and it's commendable to the work. Like, you know,
I can't swear that there were none that were antenatally consented. I think we allowed that, but most of them were consented after birth.
And I'll comment that this was a study that the entire unit, our fellows and our nurse practitioners were heavily involved with. So most of these consents were being done by our fellows. And I think A, that it's a great opportunity for fellows to do that, and B, it is absolutely indispensable with a short timeline like this for enrollment. Looking back on it, I have no idea how we actually managed to do that.
So I'm at a place now where they don't have the fellows do a lot of the consenting. They do it for their own studies, but we're part of the NRN here. And I've always been at previous institutions where the fellows had a big role in that. And, you know, the families really get to know the fellows because you're there all night. We're not there as much. They really trust you guys. And so I have found, and as Carl said, it's an important experience to learn how to do this. You know, it is a little bit of more of a conflict because you're often directly the clinical people caring for the baby, but I still think it's worth it. And if you don't have that, you're not going to have, unless you have a lot of money. Okay, UAB, somebody's from UAB, right? You guys have money. Okay, I saw Wally was here. They have money. You probably have your research nurses who come in at night. Not most places can't do that. So if you don't want to limit the number of patients by a lot, because once it gets to be around 4 p.m. till like 7 in the morning, you're going to miss, you know, half your deliveries and half your, you know, so I think it's practically, I think it's helpful to have the fellows, as Carl mentioned, and I think it's a good idea. And yeah.
Yeah, I agree it is, although there are some ethicists and some IRBs that frown upon the admixture of clinical and research in this fashion. I think as a practical matter, if it's done appropriately, it's fine.
For some of the more complicated studies, the fellows are more likely to make an error in protocol than a research nurse is. That is true. I mean, I think you have to acknowledge that, but most of the fellows are pretty smart. And once you have to train them properly, you have to make sure they understand the study. But anyway,
it's less about whether the fellows are competent in doing it and more about some pushback from IRBs and other overly conservative parties that worry that there is some more potential for coercion if it's a clinical person than somebody external. I don't happen to agree with that. I just bring it up as to be aware of that.
And I think there's probably some basis to that pushback that's probably got some validity to it, but I'm with Marty. We don't agree with that. So
great points. Dr. Almasmi.
All right. So moving on to the methods and the interventions that they spoke of, that the study had. They highlighted that very nicely in terms of the interventions in the study. So we talk about the ventilation modes, the respiratory management, the physiological respiratory measurements they took, and then the baby developmental scores. And I thought these were highlighted very specifically in a way that could be replicated. So if we talk about the ventilation modes, so they did emphasize that the ventilator they used was the Servo 300 from Siemens. And that was for both arms of the study, whether it was the SIMV mode or the PRVC. They did highlight that the trigger level was the most sensitive, that did not result in any auto-triggering, and the vents do not use any flow termination of the ventilator breaths. And with that in mind, they did highlight that if the baby required a higher rate, they would switch to the Bird VIP ventilator until the rate is less than 40. In addition to that, from the protocol update, from the protocol paper, they did mention that they had no restrictions on the I time, the PIP, the tidal volumes, or the PEP or flow rates in terms of setting up those two arms of the study.
Dr. Ryan and Dr. Kessler, on the pressure support being set to 0 in the SIMV arm in comparison to PRVC arm, why was that picked? I know in the article there was a brief line to get the maximal difference between the two groups, but in a way it's almost asking the neonate, like who's a micropreemie, to trigger enough breath with just on top of that PEEP to keep the lungs open for those pressure supported breaths, right?
I think the point was to have pure SIMV. So again, everything depends on the manufacturer and the ventilator that you have. But if you want pure SIMV without pressure support, so you set the pressure support at 0, and then that maximizes the difference between every breath being supported, as in assist control, and the SIMV rate being whatever the clinician sets, and typically significantly lower. And of course, subsequent to this publication, there were data showing that the pressure support is helpful and appropriate because small preemies breathing through narrow endotracheal tube have a hard time generating adequate tidal volume. So, no, I think that was an appropriate choice. I actually had a question, and that had to do with and an observation, and that had to do with the next point, which is the trigger level being set at most sensitive that did not result in auto triggering. That's a pretty tricky thing, isn't it? Because the leak around in the tracheal tube tends to be variable depending on the baby's head position, and I don't recall seeing anything about percentage of breaths that were triggered or not triggered, or any discussion about auto triggering, but that's in devices that are primarily adult ventilators, also used in neonates, such as the servo, that don't have effective leak adaptation, and therefore rely on manual adjustment of trigger sensitivity. That can be challenging, right? Especially as the babies get older and the leak around the endotracheal tube tends to increase. I don't know, Rita, if you have any observations about that.
So I'm not even sure that everybody on here will know what Marty's talking about, because when this first came out, some of the ventilators were still using abdominal wall triggering to synchronize your breaths. So this was one of the earliest ventilators that had flow sensitivity. So as soon as the kid took a little bit of a breath in, that's how you synchronized. The assist control mode also was synchronized by that same flow sensitivity, but then the kid drives the rate. So the answer to the pressure support thing, which I think Marty already explained pretty well, was exactly what you said. It was kind of a purist kind of thing. We wanted there to really be no additional breaths other than the rate that was set. And if you set the pressure support anything above 0, you're essentially allowing the kid to help, give more breaths to himself. They wouldn't be full breaths, but we thought it was a little messier that way. In terms of the flow triggering, the point of that sentence, I believe, if I'm remembering correctly, was that the same thing was done regardless of which mode the kid was on. And we probably should have collected the information, Marty, as to which kids this was adjusted on, and was it more likely to need to be adjusted in one arm or the other. But I do not believe because it was so routine in our unit, I don't think we collected that data.
Yeah, there's a lot out there, and there's a lot of units in the US use ventilators that are not primarily designed for neonates, and that's in part the fault of the FDA, because there's really, until very recently, only very limited access to specialty neonatal ventilators. Everybody likes these so-called universal ventilators, which I call cradle-to-grave ventilators, primarily designed for adults, but extending their reach. But they're not designed necessarily to cope with leak around endotracheal tubes. So the newest servo now measures the tidal volume in the right place. So the other thing I alluded to, and again, you're right, people probably don't fully understand what the heck I'm talking about, is when you use the volume, the PRVC, the volume is measured and regulated at the ventilator end of the circuit. And so if you inject 10 mLs of tidal volume into the circuit, a significant portion, more so the smaller the baby, gets lost to compression within the circuit. So you set the tidal volume and you measure it at 10 or 12 mLs, and the baby's getting 4 or 5. So it's a very indirect relationship between the actual tidal volume the baby sees and what you set on the ventilator. The best way to measure tidal volume and to regulate is at the airway opening. And the newest servo, the servo N on servo U, now does that.
So Ahmed, when you asked Carl for the protocol, first of all, I couldn't believe that he could dig it up and find it. And I could not believe how detailed it was. But I remember something in there, and you probably read it in more detail than I did, about using the bicore. Do you remember that contraption, Marty? And so I think that was a way to try to measure some tidal volumes better than the ventilator did. But that's all I can remember.
So you could spot check. I assume you
Right.
didn't leave it inline continuously because they would add dead space. But you could spot check the tidal volume and then have an approximate relationship. The problem, of course, is variable leak around the endotracheal tube, which again changes. It's the equipment you have that you have to work with. But I think the really important lesson I would like folks to take away from this is that clinical studies of mechanical ventilation apply to the device that was studied, not necessarily to other devices. And also the strategy that was utilized. And the strategy here was appropriate, but there are a number of other clinical trials that used an inappropriate strategy and came up with very concerning results. The most recent example of that is the high frequency study of the oscillator in diaphragmatic hernia, the Vici trial that used an aggressive lung volume recruitment strategy in diaphragmatic hernia. And guess what? The babies on conventional ventilation did better. Does that mean that high frequency ventilation is bad? High frequency ventilation used in that fashion was bad. So just to make that point, and as a reviewer and as an editor, Rita would insist, and I would insist, that in the conclusions people put such and such technique as used, or this modality as used in this study led to these results, because used differently, it might lead to different results. So you always need to look at that aspect.
And I think the other thing that Ahmed learned from that protocol is the detail involved with when do you intubate a kid, when do you extubate a kid. And you try to put most of that in a paper because it's important to understand the study. But there was way more in there than I ever remembered. It was very detailed. Don't you agree? I mean, it was a little crazy, but.
I agree with you 200%. It was a very detailed protocol there.
Very serious, you know.
I did try to cut a couple to copy some of the stuff they mentioned in the protocol here in the presentation, and we'll try and get over that. Okay. But he did mention some of the limitations of the study in terms of the air leaks that we have. They did talk about measuring the tidal volumes as well as a secondary measure in terms of the respiratory parameters, and we'll get to that shortly. So in terms of our measurements, oops, there we go. Of the study, these are the ones that they're looking at. They were looking at the physiological respiratory measurements, and they're looking at the ones at 6 hours of life. So on at 6 hours of life, 12 hours, 24, 30, 48, and then 72 hours. But then also at 14 and 28 days of age, with the 14 being their primary outcome day they're looking at, as well as 36 weeks post-menstrual age. They did comment on the dynamic compliance being measured, but you'll not see that in the results table, which I'll show you shortly. And then they defined the age of final extubation as the day in which a child was extubated and remained alive after.
Can I comment just a second on the dynamic compliance measurement issue? Mm-hmm. Because when you use the ventilator to measure dynamic compliance, of course, the ventilator uses the ventilator generated pressure and tidal volume, but babies who are not heavily sedated or paralyzed breathe along with the ventilator. The baby generates spontaneous negative inspiratory pressure, which is additive to the positive pressure from the ventilator. And depending on the degree, the contribution of the baby to the transpulmonary pressure, the dynamic compliance measurements may or may not approximate accurately what the true compliance would be. So we're only using part of the transpulmonary pressure. So folks rely on the dynamic compliance measurements a lot, but a lot of people are not aware of this, this limitation. The whole point of synchronized ventilation is we have the baby and the machine working together, right? The machine pushes gas, baby pulls gas into their lungs. It's the combination of the two that generates the total volume, but we're only measuring the ventilator contribution. So we tend to overestimate the compliance. Be aware of that.
Thank you for the input. They also defined the BPD as continued requirement of supplemental oxygen and or ventilation at 36 weeks post-menstrual age. In terms of our, the respiratory management section, they did define their goals for their babies based on gestational age. So for the babies who were 24, 26, and 6 weeks, their PO2 goals were variable. So 45 to 60 for those. For those 27 to 27 and 6, they were 50 to 70. And then those more than 28 weeks, they were 60 to 80. They did have a consistent CO2 goal for all babies, regardless of gestational age at birth.
Is that a question?
No.
Oh, okay, sorry. You said, why didn't we have a consistent goal?
No, I was saying that was consistent for all, but since you brought it up, why was that a consistent goal?
There was a gradient depending on gestational age, which is I think they're totally appropriate. I like those. I don't know how closely they were followed, but they were good goals.
Well, those are the targets, and you'll notice they weren't saturation targets. That was not trendy at that time. Everybody still got lines, and you've got PO2s.
Yeah.
And Dr. Ryan, was this all like arterial gas? I'm assuming you said everyone got lines. So, yep.
Pretty much, yeah. We weren't very smart in those days. You know, we bled kids a lot more than we do now. So.
But we also knew how to put in UACs a lot better. Nowadays, the success rate isn't what it used to be because we don't do it as often.
Well, we still put UA lines in a lot of kids, right?
Yeah, but not as many as we used to, as you said.
But I was struck when I saw this. There's no SAT targets, and you know, they were all PO2 targets. So, and yeah, there was this idea that the bigger kids, the more mature kids, could tolerate a little bit higher, could need a little bit higher PO2.
They also mentioned that the babies maintained their randomized assignment until they either met their failure criteria, they were excavated, or they passed away. And we can talk more about those because they explicitly highlighted their failure criteria. So they considered babies to have failed if they met one of these four. If they had a low PaO2 on 2 blood gases 2 hours apart, on being 100% on oxygen, and with a mean airway pressure of more than 9 for those less than a kilo, and then more than 10 for those more than a kilo. And these were the set PO2s for those gestational ages as well. They even set a parameter for those with a high PaCO2 of more than 60 on 2 blood gases 4 hours apart. Again, with that mean airway pressure cutoff. And then those with the low PCO2 of less than 30 with 2 blood gases 4 hours apart. But they also added in that this could be they could be defined as having failed if that was up to the attending neonatologist at the time to allow more free room for attending preference.
You have to put that in there for safety purposes. They won't let you get away without that. So.
But of course, clinicians tend to fail as we saw, regardless of the thresholds. That's a common theme in all of these trials. So it's not at all not being critical. That's just the fact. That's how it works, because it's not you and I who manage. It's everybody at the bedside. I will point out those are not very high mean airway pressures. So in those days, your practice has probably evolved, but this is pretty PEEP-ophobic.
The point is that all of these targets were the same for both groups.
Right, of course.
For better or worse, yeah.
Right, and not too many babies actually failed on these criteria, as I recall.
And we were worried about the low PCO2s in the assist control mode more so, you know, that they would have too low of a PCO2. We know that's bad for the brain, so, and bad for the lungs.
But of course, babies wouldn't spontaneously hyperventilate. They just slow down their rate.
And that's one thing they mentioned in the trial as well, that if a baby does meet failure criteria, they can change to the mode of ventilation to any mode, including the other arm of the study, as well as the oscillator. Here they talk about the extubation criteria for babies, and they would extubate babies if they met both of those criteria. One being the inspired oxygen being less than 35%, or the mean airway pressure was less than 6 for those less than a kilo, and then less than 8 for those more than a kilo. And then they also had that statement where infants can be extubated anytime prior to that. Again, I presume because of safety reasons, to allow for more autonomy by physicians or providers. And then if the PMA was less than 32 weeks, they would try methaxanthine before extubation. And if the weight was less than a kilo, they extubate babies to nasal CPAP.
Which implies that if they were more than a kilo, they were just extubated to room air.
I guess, because we didn't use a lot of nasal cannula in those days. We
Oh.
used this hood oxygen, right?
Yeah.
I think the point was that you were mandated to CPAP if you were less than a kilo. When I was a resident, you didn't even come off the ventilator if you were less than a kilo. So we
Right.
are evolving over time,
Right. No, I mean, and that's the other important point for the trainees is that this was a great study, and this was the first of its kind, and it was really, a landmark study. That's why it's being discussed. But practice has evolved, and you always have to consider the generalizability of findings of a study that's more than a decade old to current population, and have other practice changes evolved to the point where it's difficult to interpret what the impact or what how well these findings might translate to today's population. So, and
I learned a tremendous amount from this study, but one of the things that I learned is how difficult it is to do good ventilation studies.
oh my God, it's
And
incredibly
If
difficult.
you don't write all this stuff down, you will not have a good study, because and you have to hash it out with everybody and make sure everybody's on the same page and all of that. It's hard.
It's incredibly difficult to get everybody to agree, and at least here you compared two things that were fairly standard, right? The
Right.
hard part is when you're doing something new like high frequency, and you're trying to agree on what the control arm is, because
Right.
what's
What we
standard
normally
care?
do.
What's standard of care in neonatal ventilation? That's the hardest part.
Well, we saw from the poll, there is no standard of care.
Exactly. So that's the challenge. Ventilation studies are incredibly difficult to do, and it will always be, criticized, and it will always be, it has to be related to, it's this device used this way. That's what the findings are. Different device used this way might give you different findings. Same device used different way will give you different findings potentially. So you have to be
So
really
when we're
careful.
saying it's hard, we're not saying don't try that or don't try to aspire to do a good one. We're just saying that don't be shocked at how difficult it is. But when you think it's such a common thing that we do in babies, we need these kind of data to help understand what we're doing and whether one thing is really better than another thing or not.
Right. And it also explains why we do have such practice style variation, because there is a paucity of really good studies, because they are so hard to do, and because, again, generalizability, there's so many different devices, and so what do you do with all this?
I will point out this study was not funded. It was internally funded.
Oh, the good old days we could do, I did several large multi-center trials with no funding.
Right.
I was the PI, I was the statistician, data entry clerk, you name it. You can't do that anymore. But yeah,
Just keep going on that, because we'll just keep going.
you gotta shut us up.
All the talk.
Yeah, please shut us up, because we get carried away.
This is all good information. Just to add into that, in terms of their extubation, they did talk that babies, they mentioned that babies who were attempted following failed extubations were placed in the same mode of ventilation thereafter. And then their follow-up measurements, we spoke about the Bailey development scores. They were done at 6 to 9 months, and then repeated again if the initial evaluation had any abnormalities or suspected findings. In terms of the outcomes, we spoke about that the study did mention that the primary outcome was a proportion of infants who were alive and extubated at 14 days of age, but then the secondary outcomes were grouped as respiratory measurements that were listed in table 3, which we'll talk about shortly. And then in terms of any changes to the trial outcomes after trial commencement, they spoke about 61 babies who had some protocol deviations, with the major deviation being a different mode of ventilation. The other ones were more of weights outside the cutoff limits or incorrect gestational age, and then postnatal ages outside the limits they used. The sample size was one of the interesting things in the paper that I thought was worth talking about. And they only had a single line in terms of, or a couple of lines in the manuscript talking about that the study was powered for a 20% absolute difference in primary outcome. And that is relatively a large difference to look for. The protocol had an interesting section where they spoke about that they examined their own data from 1996 and determined that about 64 of their infants were born at less than 1250 grams, were intubated or have died by 14 days of age. So they tried to see if there's a decrease of about 20% from 64 to 44, and that gave them their sample size of about 100 per arm.
So I'm sure I don't have to explain this to most of the fellows or the more advanced fellows on the call, but when you're looking for a number outcome, a continuous outcome like sodium or FiO2 or something like that, you can get away with many, many less patients in your sample size. When you're looking for a yes or no outcome, you need a lot more babies, and you don't even need to know what the outcome is to have a table where you can say, I want to see a 20% difference, a 30% difference, a 10% difference, and you can just make up that table. There's something called Vanderbilt Power and Sample Size Calculator, and you can download it from Vanderbilt. It's a very small program. It won't hurt your computer, I promise. And you can kind of just practice the dichotomous outcome and look at the numbers. So the reason it's 20% is probably because that's what we thought we could manage from a sample size calculation. If you wanted to find a 10% difference, that number would have gone up by probably a couple of hundred kids. You know, we just didn't have that number of patients in our lifetime as faculty investigators, you know. It was probably more of a practical, you're supposed to pick something that you think is clinically relevant for that 20%, but sometimes you have to pick what you think is clinically practical, and are you gonna have enough babies to do it, et cetera, et cetera. Now, if we picked something that was a numerical outcome, like a continuous outcome at day 14, like mean airway pressure, and maybe you count 0 as the mean airway pressure if they're off the ventilator or whatever, we probably could have gotten away with fewer babies. But the more meaningful outcomes are usually the yes/no outcomes. That's why those studies, you guys read the literature, there's hundreds of babies in these studies. That's because they're trying to make sure that they can detect small differences that are important. Like if you're looking for a mortality difference, 20% is too big, right? And mortality is really important. You might want to find a 3% difference. You're gonna need 1,000 babies in that study, you know, 500 in each arm at least or something. So yeah, so that's why it's like that.
Thank you for
At
that.
least we did a sample size calculation.
Yeah, I missed that in the paper. Was that in the main paper, or was that hidden somewhere?
No, that was the protocol that I got from the angio, which again I thought was very useful to have. But
Okay,
I think it was in the main paper too. It was not very elaborated on.
I couldn't find it in the main paper. I was like, how did they get away with not not providing sample size calculation? But in those days, actually, they were not as strict about it. Today, you absolutely have to have a
And you have to have it in the paper, I can tell you right now. In those days, you still did it. The good places still did it, but you didn't always publish it because it took up some of your space, you know.
Yeah, so this is absolutely now a requirement, and it has to be somewhat realistic and based on preferably based on some actual data.
Dr. Al-Azmi, go ahead.
I think Dr. Ryan did explain that better than I'm going to try to, but this is just showing that how choosing the percentage difference that you're looking for can affect the group size that you're looking at. And picking the 20% that they opted for in the study can be seen here very briefly in terms of our results table. So even if comparing the primary outcome, the alive and extubated at 14 days, with the 41 in the SIMV percent here and the 37 in the PRVC, the difference, even though it's less than 20%, which we'll talk about in the results later, it's questionable if that is even clinically significant. And that's where you get to choose your difference in your primary outcome and therefore getting your group size as well.
Yeah, it's also important to, I'm sorry, it's important to think about the percent. Is it an absolute percent difference? Because it's the same in that table that you just showed, right? 10 versus 30, 20 versus 30 is a 20% difference in terms of absolute percent, but 10 versus 30% is very different and requires smaller number of babies than 40 versus 60%, which is still a 20% absolute difference, but requires more babies because it's more in the middle. It's not as.
There's actually a formula that as you get closer to the 50% categories, you're going to need more babies. And Rithi, who I don't know if she's on this call, but she showed it at one of the journal clubs a couple of months ago, where she told her that I gave her that slide. And so I can send it to you if you want, but it's kind of weird, but the ones that are more rare outcomes on the edge of the 10 and 20% versus like the 50 and 60%, you need fewer babies there. And it's just how the math works out when you're doing a chi-square or a Fisher exact test.
Totally.
Yeah,
If you're reducing death from 10 to 5%, that's a 5% reduction, but it's cutting it in half.
50% decrease.
Right? If you're reducing it from 50% to 45%, it's a 5% difference, but it's only a 10% absolute reduction. So
Right.
so that's why the numbers are so different. So
If it were a 4% difference in mortality, maybe you'd really want to know that and you wished you had more babies. But you don't have the table up there after you see the data. You have the table up there before you're seeing the data. And
Yep.
we probably figured we could only get 100 kids in each group. You know what I mean? So,
I mean, that was a terrific effort for no funding and essentially a single center study. I mean, it sounds like Rochester enrolled 90% of the patients.
right.
I'll talk briefly about the randomization part in the study where they use sequence generation. So they randomly assorted babies by using one of the investigators who did the assignments. It was via block randomization scheme where there was 8 infants per block, and they stratified them based off their birth weight if they were less than a kilo, and of those more than a kilo, and by center, since the study was done in 2 centers. I'll talk very briefly about the allocation, concealment, and blinding, and Dr. Ryan, you can always weigh in with that, given that this was something that you stressed upon in the beginning of the talk. So briefly, in terms of the CONSORT 2010, we talk about blinding as defined as withholding information about the assigned interventions from people who are involved in the trial, and that might potentially influence, and that might be influenced by their knowledge. Whereas allocation concealment is more of the mechanism that prevents foreknowledge of treatment assignment and thus shields those who enroll participants from being influenced by this knowledge. So really the blinding
I think Carl told you this, but I don't think we put it in the paper. I did the block assignment and I was the only person who knew the block assignment. And I promptly forgot because I would never remember. But in other words, the investigators there each day enrolling the kids had no idea how large our blocks were. And that is very important. But somebody had to know because we didn't have an off-site data monitoring center or something, you know. I made the cards, I made the whatever.
And those cards were placed in a sealed opaque envelope
Yes.
in the study. And then that's going to be you're the investigator who did that with a random allocation sequence. And then there was no blinding like you suggested, like you said initially, because of the difficulty in doing so with all those goals of ventilation that we were looking for in those 2 arms of ventilation modes.
Yeah, just some studies you just can't blind.
Moving on to the statistical methods that were used, and Dr. Ryan did highlight that because of this being the outcome they were looking at was sort of similar to like a yes or a no modality that required a relatively larger number. So they spoke about how they categorized their different their different groups and their measurements and their variables that they measured. But they did talk about that there was an intention to treat analysis as part of their statistical part or evaluation of the outcomes. Briefly about the results, the participant flow diagram is there, which I'll go to next. So they'd have 667 patients that were eligible initially, but then only 213 were randomized to either arm of the study. 108 got the SIMV group, whereas 105 got the PRVC group. Talking about the SIMV group, 108 got the allocated intervention. 36 of those met the failure criteria, and 108 were analyzed. Whereas in the PRVC group, 104 got the intervention, whereas 1 did not receive. I believe that was lost to follow-up. And then that was excluded from the analysis because of that reason. In terms of the recruitment part, we spoke about them recruiting babies from 1998 to 2002, and that was shortly after the protocol was written. The results
Stop the
section.
study because the enrollment criteria, the enrollment sample size was met.
Mhm. Oh, true.
Like nothing bad happened. We just stopped because we met the number of babies that we needed.
Sure. I'll talk about the results in terms of the tables because that's easier to go over the results they tried to express. Let's see. So in terms of the demographics table, they did highlight everything with nothing that was remarkably different in terms of the ratio or the different the baseline characteristics, the baseline, the birth rate, the gestational age, and the sex, the gender. The need of maternal glucocorticoid treatments was mentioned as well, which I thought was useful. And there was no difference between that, with 80% in the SIMV versus 83 in the PRVC.
I would like to make a comment. I've learned a lot since I did this study over the last, 15 years or whatever. And most times when you have a cohort of so many babies, less than 1,250 grams, if that cohort is being rolled evenly, you're going to have more babies toward the higher gestational age. They're almost always never normally distributed. I've learned this now because I've gotten smarter and I've looked more carefully at it. So even though we reported mean and standard deviation for our gestational age and birth weight, probably that population is more skewed than we really recognized. I don't know, Carl, you probably don't remember, but I'm just mentioning that we probably just didn't know that we should have reported as median.
Yeah, you're right. I don't remember, Rita, whether they skewed the data.
For those of you who didn't notice, Dr. D'Angelo had another conflict for the last half hour, but he's back now. So
just it's a subtle difference and a subtle finding, but I was just curious to see why the 4 infants in the SIMV group and the other 6 infants in the PRVC group did not receive surfactant. Was like in that era, like giving surfactant was almost always in the delivery room or right after birth. So especially in these kids who are already intubated, I was
and especially in Rochester.
Yeah, there you go. But yeah, once intubated, you get surfactant, right?
I mean, I think 96 and 92% is pretty good. And there are probably kids who got ventilated and who were on 21% and really didn't have a lot of clinical RDS.
So back in the day, as you said, the very tiny babies got intubated automatically, right? They may not have had much lung disease and therefore didn't meet the surfactant administration criteria of 30%.
So in those days, Sai, am I saying your name correctly? We believed in meeting certain criteria on the ventilator because all of the randomized controlled trials that were done were on ventilated kids and kids who met certain criteria. For a while, it was 40% and +7 CPAP. Sometimes it was, got down a little lower. Then there were some prophylactic studies. So not every single kid who got ventilated automatically got it sometimes. So that's probably just, the really great kid who was just happened to be ventilated.
And I'll agree with that, it was probably the older kids because all the younger kids were intubated and given surfactant in the delivery room. So these would have been older children who ended up getting intubated after that.
Thank you. Dr. Al-Hamzi?
Moving to the remainder of the results that they had in the study. This is the primary respiratory parameters that they're talking about between comparing the 2 modes of ventilation. The ones that were statistically significant was the respiratory rate, the PIP, and the tidal volumes. So comparing them at 6 hours of age, the SIMV mode did have a lower rate compared to the PRVC, but did have higher PIPs and a relatively higher tidal volume compared to the PRVC. This carried on to the 12 hours of age as well, with the lower rate here, but the higher PIPs and the higher tidal volumes.
So these are remarkably low PIPs, and of course, tidal volume per kilo of 18 ml would not be what you would actually do, right? But that's what we were talking about before, that much of that tidal volume is actually disappearing in the circuit and leaking around the endotracheal tube.
Right, and this ventilator, because it did measure back at the box, I'm not even sure that tubing compensation was available on the Servo 300. I don't remember.
I don't think it has that. And even on the Servo I, if you have any leak around the endotracheal tube, the leak compensation doesn't work very well.
That's correct.
So you have to take these tidal volume values with a grain of salt, a large grain of salt.
Then in terms of the respiratory outcomes, they're looking at as well, the primary being the 11 XCD at 14 days of age, and that they try to look as well in terms of the same outcome at 28 days and 36 weeks, but there was no statistical difference for those days as well. One interesting table that I thought was nice to read was
Can you go back for a second? Because I have to say, to have that many percentage of kids be still well, no, never mind. I've got it wrong, but it just seems like alive without BPD is pretty darn good for a study from 15 years ago. I'm amazed at that with all these kids being ventilated. Anyway.
Yeah, I mean, I don't know what the distribution was. Was this all stratified? Was it
stratified less than 1,000 and greater than 1,000?
Right. And I think there were more in the greater than 1,000 grams category, which
even still the Von numbers now for less than 1,500 grams is 40% BPD, right? Yeah. It's not bad.
No, it's great. I mean, you guys were.
I didn't know we were doing so well.
Did well.
Sorry, go ahead.
Okay. In terms of the failure of ventilator mode, we did talk about that the majority of deaths occurred in the first 14 days. The SIMV of those, the 36 that failed, 25 of those were switched to the PRVC mode, and then 8 were switched to the oscillator and 3 to other modes, showing that the unit probably preferred using a PRVC mode. Whereas from the PRVC, from the 21 that failed, only 1 continued to be on the PRVC and 15 were switched to the oscillator. I thought was interesting.
And I'll comment that Rita talked earlier about blinding and the importance of blinding, despite the fact that, as you will have talked about while I was away, that the extensive requirements that we had for failure, that there was still always the attending neonatologist's discretion, and you're right, there were biases among the neonatologists that we couldn't entirely eliminate.
That's life. It's a real life study. You've got to deal with that.
Yeah. It would have been lovely to blind it, but I still couldn't figure out how we could have done that.
I don't think there is any way you can blind a study like that.
I have to say, when a study comes out against your own bias, like not agreeing with your bias, I always feel it's a more powerful study. So I think I was one of the people, Carl, you can maybe remember, I believed PRVC would be better. It made more sense to me that the kid should set his own rate and he can, get a certain amount of volume and be supported with whatever pressure he needs. And doesn't that sound like it would make less BPD kind of thing? And it didn't turn out that way. And I could tell you, I probably did have a bias, but if the kid was in the study, I wouldn't have switched him just for my bias. I'm like very strict on myself, but not everybody is. So.
Well, we did have it. We did have equipoise within the among the investigators.
Yeah, I think Carl thought SIMV, or Carl or Patty thought SIMV was going to be better. And I said, well, then that's the perfect study to do, right? Because nobody agrees like one is so much better than the other.
Yeah, it's like Abbott and I about PDA. He likes to treat, I like not to treat. So we're doing the trial.
Yeah, only 15 years.
Yeah, when you can figure out the PDA thing, please let us know.
Yeah.
The rest of us, we're all going full circle. We're doing what we did 20 years ago, then we stopped doing it, now we're doing it again, Anyway, don't even bring that up.
That's what reminds me. Yeah.
Just moving on to the other outcomes of the study, they did talk about the occurrence of PIE, pneumothoraces, pulmonary hemorrhage. None were majorly significant between the two arms of the study. In terms of their measurements, they also looked at the neurodevelopmental outcomes of such babies, and there was no significant difference between the two arms as well. This is the Kaplan-Meier curve that where we can look at the time at which babies were extubated here, with the 80, just under 83% or so, where there was the reason for why babies have passed away, and that's where the curve doesn't hit 100%.
I think one of the challenges with the extubation endpoint is that I don't know if it was still true then, but there was certainly a time that we wouldn't extubate a baby less than 1,000 until they got to 1,000 grams, right?
I think we were moving a little past that by this time, but Marty makes a good point. I think we had gotten out of that a little bit. It was more when I was a resident than that was the case. And this was sometime after that. But yeah, everybody stayed intubated to grow.
Right.
Less than 1,000 grams.
That was the thing. So
we grew them,
again,
but their lungs were terrible.
right. And I only bring that out as a teaching point, that you have to kind of look at what else might be influencing your primary outcome, and are there things that might be masking a difference, if in fact there might have been one, but for the fact that we kept babies on the ventilator till they got to 1,000 grams regardless.
You know, when I looked at this again, it did look like there was a little separation between, like,
For a while, it looks like
7
there's
days, like the first end of the first week till like the 7th week or so, then everything evened out. But it did look a little bit like the two lines maybe were separating a little bit.
And then they came back together. And would be kind of interesting to see the same data by gestation, by size stratum.
Yeah,
if the stratum,
good idea.
If the largest stratum, there was a separation, and the smaller one, maybe not so
I'm
much.
guessing we looked at it and there probably wasn't anything interesting to say.
Probably.
I don't remember whether we looked at it, but.
Because your 1,200 grammer is very different from your 700 gram.
700 grammer, yeah, it's true.
And our criteria for extubation were not, you needed, if you were over 900 grams and you met other criteria, you needed to be extubated.
Right.
So we were trying to enforce extubation at what we at that point thought was a reasonable weight.
But as Marty's saying, if you were less than 900, you were allowed to ride.
That's correct.
And
that's correct.
So, you know,
And
so maybe we were still a little bit better than 1,000 grams, but still kind of chicken, a little bit more chicken to take the smaller kids off.
I think if I remember properly, we pushed it down from 1,000 to 900 right before we started the study.
You were mavericks then, you know.
Yeah, you were absolutely on the leading edge. You still are.
Just to talk briefly about the next steps before the discussion section that I think will take a good chunk. But the consultant asked for harms. None were mentioned in the manuscript itself, but the protocol did talk about a theoretical risk of overventilation in the PRVC mode, which we have alluded to earlier on in this discussion. But that was also in the consent form given to the families. Again, this was not in the manuscript, but in the protocol that was mentioned.
And this is, and I'll just comment that is in part, I mean, that was a problem with the ventilator rather than the ventilation, because if, as Marty already mentioned, if you had a leak, you really lost reliable triggering, and the ventilator tended to auto trigger. That's been corrected in subsequent models, but that was a problem then, and we would see children who were overventilated because they were auto triggering.
Yeah, that's a challenge with the uncuffed endotracheal tubes and leaky things. So, right.
So that gets us to the limitations of the study. I think having the SIMV maximum rate of 40, where if you go above that, to switch to a different vent might be a limitation or a confounder there. We did talk about the role of the leak around the AT tube, like Dr. Kessler said. It's hard to rely on the value that you have there from your tidal volumes. And then the application of the failure and extubation criteria based off attending preference, I think is a limitation, but it's a thing that you have to add there. We spoke about the sample size calculation being the 20% for looking for a difference, and then the unmasked intervention, which again, you can't do a ventilation study without really unblinding the vents.
I would have to add to your list of limitations the fact that it wasn't pure SIMV versus assist control. It was SIMV pressure control versus AC with volume targeting. So it would be a challenge to tease out whether the other difference between the two arms might have augmented or negated any differences that would be resulting purely from a difference in the triggering method, right? It's more than one.
Well, the triggering is the same in both modes, but we did,
Not trigger. I mean the mode of synchronized.
yeah, we did talk about this. We decided that if one was better than the other, then we would do another study to look at which of the two, was it assist control versus SIMV? Was it volume guarantee versus pressure control?
But then the influences might have been in opposite directions.
Could have been, but then both modes were still the same.
Right.
And these were the
But
two
you,
most
but you
popular
wouldn't have,
modes
but
that we
you
had.
wouldn't have necessarily answered the question.
Right,
of
we
it's-
wouldn't have answered the mechanistic question, but we would have known that giving one treatment versus the other to the baby was no different.
Right. So relevance to the question, is PRVC better than as a pressure control SIMV, but not specifically answering the question, is assist control better
Correct.
than SIMV purely in pressure controlled mode?
Correct.
Which is sort of the stated purpose of your study, but it is complicated by the other differences. I just think that has to be acknowledged as a limitation.
I agree with you, Marty. I think had I been a little bit more sophisticated about the way I thought about it, we probably would have thought about it as a comparison of two strategies versus a direct physiologic comparison between two otherwise similar modes.
Right. So no, it's a good study, and it does answer a question. It's important to think about it very clearly about what was compared and how we can generalize that to let's say other devices.
I agree.
And also, like in the best interest of time, like also the challenge with some of these ventilator studies is the high crossover rate, which was also addressed in this particular study. It's extremely challenging, like especially to avoid exposure to one arm versus the other, like we've seen in this study too. So
right, and that gets down to the ethics of research and the autonomy of the clinician caring for the child at 2 o'clock in the morning on a Sunday, who has to be able to do what they think is best for their patient, whether what they think is right or not is separate issue.
But I guess almost all of those crossovers were for hypercarbia. And you're not going to let a kid sit there hypercarbic if you have something else to try, basically.
Right, but the criteria. But they didn't wait for the threshold to be met, the threshold that you established. Right, majority of the crossovers were, as in my studies, were based on clinician discretion, not necessarily meeting the strict criteria that you established. That's always a difficult balance, and it's just what it is. It's, again, for the benefit of the trainees on the call. This is the reality of clinical research. Unlike in the lab where you can control everything, in real life you can't. But then again, you can make the argument that, of course, real-time pragmatic studies translate better into real-life benefits or not. Something that's so strictly controlled that it cannot actually be replicated in real life, maybe it's not that useful.
Go ahead.
I think we've spoken about the generalizability of the study extensively in terms of the difficulty with replicating the study, in terms of the different modes of ventilation that we were using in the study in particular. Just a question that came up as I was talking to a couple of colleagues about the applicability of the volume guarantee mode. I think we've touched on that, where current volume guarantee mode, AC assist control volume guarantee, is relatively different than what it was before. And I think Dr. Mukhtar mentioned initially about when you pulled up the poll with different people having different modes of ventilation for their preemies, just tells you that probably gives you a sign that the volume guarantee mode that's currently used is quite different than what it was in the past.
Yeah, it's
May be different, but conceptually, I think it's similar.
no, in principle, PRVC and volume guarantee are very similar. It's the same basic principle. You measure tidal volume compared to target, and then increase or decrease or leave the same your inflation pressure. The key difference is where you measure the tidal volume and the fact that there is leak compensation and those sorts of things. But in principle, they are the same approach. The implementation is a little bit different, and it is what it is, and it is challenging to use optimally. But it deals the volume guarantee with the Draeger device. It copes much better with leaks. It measures tidal volume at the airway opening, so you get accurate tidal volume data. But there's still lots of different ways you can use it badly and have bad outcomes.
And I'll just comment that when I entered this poll, we still primarily start these kids on, particularly the very small ones, on SIMV pressure control. And that is solely because of the tool that we have, which is the Servo I, which is a market improvement on the Servo 300, but it still measures tidal volume in a place that's not very useful for trying to deliver accurate tidal volumes to a very small baby. And we just, if we had the right hammer, we would be able to, we'd be able to use a different mode. But it's, I agree with you, Marty. It
So
really
the last two institutions I've been at, we pretty much start with volume guarantee for everybody. I think we're using Draeger here, and I can't remember what we used at MUSC. It was like, as I was telling you guys, each place is different. At least we've got volume guarantee as at least a pathway to talk about different ventilators amongst the different choices.
That was a fantastic presentation, Dr. Al Azmi, and thanks for all your wonderful insights. I will ask a concluding question, which I think ties up a bunch of questions from our audience. I'll pose the same question to all three of you one at a time, and I'll let you all speak your opinion on it. Do we have enough evidence to know the right approach, at least with the caveat that one size doesn't fit all, in regards with ventilation strategies in neonates? Or if we don't have enough evidence, how would you recommend designing an ideal trial in an ideal world that would help us identify that evidence? I'll start with Dr. Ryan.
Well, I was going to defer to Marty, but I will answer that when I saw your poll, I thought one of the answers was going to be not to ventilate. And I think that's kind of, where our data are leading us. And then if you say, well, we're not going to ventilate, how should we manage surfactant? I think the data are leading us to LISA, to less invasive surfactant administration. I think surfactant is, some of the studies that compared CPAP to ventilators, also just the way that works is these guys, the ventilator kids it's flipped, my hands have flipped, and now I can't remember which is which, but the kids that get intubated get surfactant. The kids at CPAP have delay in surfactant. I believe that surfactant is probably still very useful and very helpful. LISA has shown that that's an advantage over ventilation, over in and out surfactant, over CPAP alone, et cetera. So not to rephrase your question, but I think just really thinking, is ventilation the right thing to do for this baby? There are things that we do like permissive hypercapnia. I see Wally Carlo was on. I think he's off now. I don't know. The ventilator is not the enemy. There's a place to use it when you need to use it. And do I think there's any advantage to one kind of mode over the other? I'm not completely convinced. I still have a tendency to look at the PIPs even when they're on volume guarantee, because that's how I learned, So I don't think there's good enough data, Marty will hopefully correct me, to say that one mode on a ventilator is better than another.
Well, so I certainly agree with the if you don't have to ventilate, don't. I agree with the concept that it would be lovely to not have to choose between avoiding ventilation and giving surfactant. I'm still holding out for nebulized surfactant, the truly least invasive, because LISA still involves ramming cold steel down the baby's throat, so it's not so non-invasive. So nebulized is my top choice. But as far as we all know that babies less than 26 weeks often, even though many of them leave the DR on CPAP, eventually fail and end up needing to be ventilated. So we need to talk about best ways of ventilating, even when we know that avoiding ventilation is the best if we can. There are several meta-analyses that have looked at volume versus pressure as the primary control variable, and they are a mixture of modes. They're not all VG. And they do suggest a pretty impressive improvement in outcomes, a little more than 25% reduction in BPD, close to 50% reduction in severe IVH or PVL pneumothorax. Those are fairly compelling data, although it's not perfect. A bunch of small studies don't equal one really well-designed controlled randomized trial. And as Carl knows, there is still an approved protocol in the NRN, which will never be prioritized for funding because it's too controversial. I have a protocol that was developed and approved to compare VG, volume targeted ventilation. And again, the problem is there are different modes, different people have different ventilators. So to answer the question that I had posed, we ideally would have a large randomized multi-center trial that compares volume as primary control variable versus pressure as primary control variable. The devices are a real challenge because they're not all designed with the same capabilities, especially the leak around the tracheal tube and accuracy of tidal volume measurement are the big challenges. As a point of disclosure, full disclosure, I have had a relationship with Draeger since the 1990s because I found their device to be the one that does the best job for my babies. So I have to disclose that I have done lectures that were supported by them, and they supported a large clinical trial. So I might be biased, but the reality is that the rest of the world has access to many devices designed for newborns, whereas in the US, it's been very limited until recently. It's been the Draeger, then the Servo N, the new Servo, does measure tidal volume at the airway opening and regulates based on that. So it's definitely a step in the right direction. I don't think it has quite the same compensation for leak around in the tracheal tube, and that is a challenge. But it would be nice to have the single definitive trial, because I'm not a huge fan of meta-analyses that put together a whole bunch of different studies, except when they agree with my bias, of course.
Or when they're very homogeneous studies.
Yeah, when they're homogeneous studies, but that's always a challenge.
And Marty, using the Draeger, which you do have a relationship with, but you said you like how it takes care of babies, what would be the two modes that you would compare? I think that's what Sai's asking for. What's the next best study that you could do? And I like the idea of using the same ventilator for the two different modes because it builds in a lot of equality between the choices.
Right. You eliminate other potential confounding differences. So, you can, of course, marry a VG with any of the synchronized modes. So you can use VG with a SIMV, you can use it with assist control, you can use it with pressure support. But AC is the most widely, AC-VG is the most widely used combination. My colleagues are still, many of them, clinging to SIMV pressure control. So one could argue, one could argue that one could compare the two most widely used approaches. But the problem there is similar to your study, that there are two differences, right? So if you wanted to isolate the effect of volume targeting, then you would do AC-VG versus AC alone, AC pressure control versus AC pressure control with volume targeting. So AC-VG would be, I think, my choice. You could argue, though, that people don't often use AC by itself. They don't use AC-VG. They typically use SIMV. And so, as you reasoned, those were the two modes that were used in your NICU most widely, and that's why I think you compared those two, and that there's certainly a considerable logic to that, but it does confound.
They were both the newer things. Assist control was new and volume guarantee was new, and so that's what everybody was trying. So
I totally understand. I mean, those were the two things that were in use, and which one is better is a fair question. But it's not a pure, SIMV versus assist control question. That question has never been fully answered to my satisfaction.
That's why we can't give you a good answer, Sai, okay, because there is no answer.
Yeah, it's so we need several studies. We need the study comparing SS control against SIMV, and it would have to today in the 21st century, it would have to be SIMV with pressure support, right? You wouldn't set your pressure support to 0 anymore because people don't do that in 2020. Back in the day where you did this study, that was widely practiced, but today you would probably have to use SIMV with pressure support, and you probably wouldn't show much difference if you use the pressure support optimally. To
Right.
me, it works. It's just,
that's why we made it 0.
it's just needlessly complicated because you have 2 sets of parameters to adjust and to potentially to wean. So I use a SIMV.
Give Carl a chance to answer.
I'm sorry.
Should we give Carl a chance to
Oh,
answer
I
question?
think we definitely should.
So I'll agree with nearly everything that Rita and Marty have said in terms of probably the best thing to do is avoid ventilation. But if from there, then as both of them have said, the question, in order to answer the question, you need to know the question that you're asking, and let's just assume for the moment that we actually wanted to answer a question about pressure versus volume. It would need to be multi-center. People would need to use the same ventilator, which then you'd need to either enroll centers that all by choice were using that already, or have an extraordinarily expensive trial. And you'd need to do other things to try to limit crossover, and to get a study that was clean, you might very well have to go to something like you might have to tell investigators that they would have to go to a high frequency mode if the babies failed their assigned mode and not allow crossover in the trial. So it would be the complete opposite of a pragmatic trial, but it would come closer to answering the physiology question. Whether that would translate into practice or be generalizable, I think is a separate question.
I mean, I can live with crossover if the primary outcome, like we looked at 14 days. The problem is then you have some effect on later things like BPD or whatever, but I don't mind the crossover for actual meeting failure criteria. It's the discretionary crossover that gets very messy.
That's correct.
You know, and so I think what everyone is saying, Sai, is that because you sounds like you want to do a trial, right? So I think the problem is if you pick the pressure versus volume question, people are going to say, well, then we have to figure out the assist control versus SIMV question. So whichever one you pick first, everybody's going to say you should have done the other one, right? I mean, that's how this happens. But you pick one, you pick what you think is the most interesting, what your equipment's going to support, and go for it. You know, tell Dr. Greenberg and Dr. Whitsitt that you need a little bit of money and a little bit of time, and you will do this. And you've got other centers in Ohio, you know, that you can talk to.
Yep. This was great. No, thank you, everyone. Like lots of great learning and lots of great points. And thanks, Dr. D'Angio and Dr. Ryan, for publishing this paper and such a thorough and extensive study for that generation and teaching us all on how to do things. And Dr. Al-Mazmi, thank you so much for your presentation. You did a fantastic job and you're thorough. And Dr. Kessler, thanks again for coming and joining us and teaching us all your valuable insights on this topic. Thanks, everyone.
We thank you for including us, and Ahmed did a very nice job. Thank you.
Thank you.
And before you log off, there's a link for the survey. If you can fill up, will be great.
A link for the what? Say it again.
A survey for
feedback for the session. Yep.
Oh, okay.
Thank you.
Thanks for having us.
No,
Good
thank
job.
you.
Great
Thank
job.
you.
Bye-bye.
Thank you.